Hi, my name is Sam Ord. I'm an ICU specialist at Nepean Hospital in Sydney. It's a real privilege to be able to talk to you today. Thank you very much to the faculty for inviting me. I'm really sorry I can't be there in person, but I hope this makes up for it because I'm going to try and do a live dissection and we'll talk about normal valvular anatomy. As we look at the heart, it sort of sits in your body like this, where we've got the you can see the right ventricle that sits here, sitting at the anterior part of the sort of heart, so it could be called the anterior ventricle. And then you've got the left ventricle that's behind. You can see that we've got the LAD, the left anterior descending coronary artery, that sits down here at the front, and the apex of the heart is predominantly taken up by the left ventricle. As that right ventricle dilates, it starts apical crowding that comes on into it from there. If we were to have a look at what's known as like the surgeon's view, if I hold it up like this, the tricuspid valve is almost the most anterior valve. You've got that pulmonary valve as well. It sits towards the front of the heart. The aortic valve right in the middle of the heart. It's and you can imagine if there are infections that are associated in this area, they can go anywhere in the heart. And then you've got the mitral valve just behind it. The structures that have been taken off, there would be that's sitting just in here from sort of about the 10, 11 o'clock position through to the 9 or 8 o'clock position would be the left anterior, the LAA or the left atrial appendage that sits here. And as you can see, a little nub in here of the right atrial appendage that's left. We're going to start off by talking about the mitral valve, then we're going to talk about the aortic valve, then we'll talk about tricuspid, and then the pulmonary valve. So the mitral valve is going to have two leaflets. I'm pulling up here on the anterior mitral valve leaflet, and there's the posterior mitral valve leaflet. That anterior mitral valve leaflet is closely associated with the aortic valve. If ever you're seeing the aortic valve, the one next door to it is always the anterior mitral valve leaflet. If you see the septum, anything in front of it or associated with it is the anterior mitral valve leaflet. The anterior mitral valve leaflet is bigger than the posterior mitral valve leaflet. Both of them have 3 cusps. You've got, again, left atrial appendage, which is sitting at the front here. That is anterior. That's going to be associated with A1, P1. You then have A2, P2, and then at the back of the heart, you've got A3, P3. Let's take something like transesophageal echo. Okay? We look with transesophageal echo from the esophagus, obviously, looking at the heart, similar to the way that we're looking at the heart right now. Okay? When you're at 0 degrees, the angle of interrogation you're looking down through the heart is somewhere like that. Okay? If I push the probe in, I look more towards the back of the heart. So I'd look more towards, say, if I'm at 0 degrees and I push the probe in, I'm looking more towards P3, A3. If I pull the probe up, you'll notice the aortic valve starts to come in. I'll be looking at the left atrial appendage as well, potentially, and the aortic valve coming in, I'll be looking at A1, P1. If I'm somewhere in the middle, I can be getting anywhere from A2, P1, P2, or if I'm a bit above, P2, A1, A2, that kind of area. It depends where you're sitting. If I now hold my probe right in there, if I now look down to have the main fulcrum of what I'm looking at being down through that, straight the way down through that left ventricle, and I rotate, it rotates round clockwise. Okay, so if there's 0 degrees, as I rotate round clockwise to say 60 degrees to get the commissural view, I hope I can persuade you that I'd then be looking through P1, A2, P3. If I look to the patient's left, I'd be looking through something like P1, P2, P3. If I look to the patient's right completely, I might be looking through A1, A2, A3. Okay? So all depends where we're looking to the patient's right to the left when it's 60 degrees. So 0 degrees, 60 degrees. If I then come around to 90 degrees, I might be looking through A1, A2, P3. And hopefully you get the pattern now. If I start to come down around the way to look through the aortic valve, I've got to be looking through A2, P2. Okay? So just one more time. Aortic valve, mitral valve, big anterior leaflet, smaller posterior leaflet, A1, A2, A3, P1, P2, P3. 0 degrees, I'm looking down through something like P2, A2, A3, or when I'm looking in that direction. As I rotate round to 60 degrees, commissural view, classically looking at P1, A2, P3, when you get that little trapdoor feature. As I come around to 90 degrees, it could be A1, A2, P3. 120 degrees, easiest view to think about, and that's looking through A2, P2, when you're looking through the aortic valve. It almost looks like a Pringle, right? Where you've got that anterior-posterior distance, and then you've got this fibrous skeleton around it, which is built off. This fibrous skeleton's got two sort of trigones, your right and your left trigone that sit here on either side of your aorta. You've got this kind of circular structure through the aortic and the mitral valve, and you can sometimes feel that, and that's why they often use that as anchor points when they're doing minimally invasive procedures on the mitral valve, or the replacements happen from there. You don't have that so much on the right side. The trigone's much smaller, it's just got a smaller C shape to it. So sometimes you can't feel it quite as well. You've got two papillary muscles in there. You've got your anterolateral papillary muscle and your posteromedial papillary muscle. And what we're going to try and do now is I'm going to show you about the anatomy of those by cutting down through P2. So I'm going to imagine there's a line down here, like the 120 degrees in the mid-esophageal view, through the aortic valve all the way down through here. Which would be a bit similar to your parasternal long axis view. And I'm going to try and cut through P2. Don't chop your hand off. All right. Okay, see how well I've done. So what I hope you can see here is, first of all, the aortic valve sits right at the front there, straddling it. It's almost like there's a C shape that's trying to grab it. You've got the anterior mitral valve leaflet, and that anterior mitral valve leaflet is much bigger than this posterior mitral valve leaflet. So anterior is going to be here. Remember the left atrial appendage just at the front here. If I now fold it open, I'm going to have A1, A2, A3. I'm going to have my small little nubbin of P3, super cute sitting in there. And here's the P2 that I've chopped through, slightly larger P2. Probably, yeah, P3 sitting in there, A2. Here's P2. And here on the other side is the other half of P2, and there's the really small P1. We got two papillary muscles. Posteromedial, anterolateral. These papillary muscles provide cordae to both leaflets, right? Half of these cords are to the anterior mitral valve leaflet, half of these are to the posterior. On this side, half to the anterior mitral valve leaflet, half to posterior. So each papillary muscle is sending cordae to both leaflets. And that means that if you get problems with cordae or one papillary muscle, it can affect either your posterior or your anterior mitral valve leaflet. But one of the things that surprises me from doing this, and I love doing this dissection every time, because, I mean, as well as it being incredibly beautiful, this structure, it's also really tough. A bit like my wife. No, that's not film. So, these, I mean, I cannot break these with my finger. I'm giving them a lot of love there. I cannot break them. And this is a tiny little lamb's heart. Imagine how strong they are in your hearts. These are hard to break, but they can break if you get ischemia to these papillary muscles. If we can remember the coronary artery anatomy, if I just fold this up a little bit. So we'll come into the aortic valve in just a second, but you've got the LAD that comes off the left main. So the left main is coming off your left coronary cusp here. It then separates into your circumflex. I'll just hold it like this. It then separates off into your circumflex that comes around here and supplies the lateral wall of your left ventricle. You've got your LAD that supplies this front portion of your heart. You've got your right coronary that comes off your right coronary cusp that supplies this right side of your heart and inferiorly. So if we just think about the circ and the right coronary that come through here, they're both in the area of this papillary muscle, your posteromedial papillary muscle, which classically has a single blood supply, normally from the left coronary, normally from the circumflex, but can also be from the right coronary. So this is the most likely one that can break. The anterolateral papillary muscle often is supplied by the circ and the LAD. You can obviously get variation. Let's talk about what happens with that. So if we imagine, first of all, let's talk about prolapse, difference between prolapse and flail. So prolapse is when you get nasty regurgitation, but the tip of the scallop points back down towards the left ventricle apex. So if you imagine I'm pulling it up like that, you can imagine there'd be horrible regurg that would come through if these were redundant, if I sort of stretched them a little bit and let it come back, but the cusp edges pointing down towards the LV apex. As opposed to, let's say we have now 100% left coronary artery occlusion and this papillary muscle gets knocked off. Okay? What we can see now is you can imagine if that was floating back, you'd get a flail where the cusp edge points upwards towards the left atrium. Okay? So flail here from a papillary muscle rupture as opposed to prolapse that lifts up. Okay? You notice the cordae, three different types of cordae. You've got primary, secondary, and tertiary. Primary come off from the top of a papillary muscle edge. Secondary can sometimes come from a little bit further down, but insert into sort of underneath on the underneath of the scallop. Tertiary, see if I can see any tertiary in here for you. Tertiary come off the ventricle wall rather than a papillary muscle, and I can't see any on this one, but they come up from off the not from a papillary muscle, but still attached underneath, and often more commonly seen on the right side on the tricuspid valve. You'll notice lots of other sort of fibrinous structures where they don't attach to the scallops, and we call these tendons or false tendons, right? And you often see those when you're looking at echoes. Okay. So what we're going to try and have a look now is at the aortic valve. The aortic valve has three cusps, as we know. It's got a left, a right, and a non-coronary cusp. If we have a look from the top down here, you can start to see that diamond shape, if I can pull it down straight. And you'll notice so here's the non-coronary cusp right next door to the interatrial septum. There's the right coronary cusp next door to the right ventricle. And in here is the left coronary cusp. And that junction between that non and that left coronary cusp is right down the center of this A2 anterior mitral valve scallop, A2 mitral valve leaflet. So what I'm going to do is I'm going to try and cut directly down the middle of that. And now if we fold her open, you get an idea of the aortic valve. So one of the first things you can note is how closely associated this aortic valve is with the mitral valve leaflet. This aortomitral curtain, it's tiny, right? So again, if you had infections or an abscess that's starting to sit around your aortic root, how close that can be associated with mitral valve or your atria or something like that. So, it's a big deal. We can see that we've got three coronary cusps. We've got the left coronary cusp associated with the entrance, the left main. It comes down through there, left coronary ostia, if you can see that just in there. We've got my right coronary cusp with the right coronary ostia. And then in here is the non-coronary cusp that doesn't have any coronary artery associated with it, but is right next door to the interatrial septum. One of the things I'd like you to have a look at is there's a three-dimensional structure to aortic valve, and forgive me if that sounds silly, but right in here I've got that insertion point of that, here the right coronary cusp, and it inserts down here into the ventricle. So it's all this ventrico-aortic junction, if you like. And then this about a 5-7 millimeter height to where the sinotubular junction starts right at the top up here. So again, there's a three-dimensional structure to it, and you can, in a given idea, there's obviously no papillary muscles or anything. We just got these semilunar valves that try to help, prevent any regurgitation in there. And it's that height that helps provide that tension to stop those leaflets prolapsing, right? So that those insertion points in that sinotubular junction are absolutely essential to help prevent any regurgitation. And that connection that you have between that left coronary cusp and that non-coronary cusp is right down there through that junction between the two of them, looking down through A2 of the mitral valve. If we now have a think about the tricuspid valve. So this tricuspid valve obviously has three leaflets. It's got the anterior that sits at the front here, the largest one. It's then got the posterior that sits against the free wall. And then it's got the shortest sort of radial distance in here, which is for the septal tricuspid valve leaflet. Okay. There are papillary muscles, cordae, and all the rest of it. You can see the coronary sinus at the back here that's emptying into the right atrium. So we're looking from the right atrium down into the right ventricle. What I'm going to try and do is make an incision between the anterior and posterior tricuspid valve leaflets. But maybe just before I do that, one of the things that I'm going to ask you to think about is as that RV dilates, you can imagine that it moves out this way. So it's the free wall that dilates. And that means that classically you start to get separation between that anteroposterior commissure and that posterior septal commissure. And that's where we start to get that sort of central regurgitation that happens with tricuspid regurg when you get RV dilation. As we look down into it, I'll try and find that junction in that free wall between that anterior and posterior leaflet, which I think is somewhere around there. See how we go. I'm just going to chop down towards the RV apex. Not bad. So you get an idea here of the largest, I think I maybe just took off a little bit there, but this is the larger anterior tricuspid valve leaflet. Largest anterior tricuspid valve leaflet that's sitting over here on the right. I've got the small little nubbin of a septal leaflet that's in here, which has this shortest radial duration. And then over here, attached to this muscle in here, I've got the posterior. I think maybe I've got a little bit of the anterior in there. So I've got the posterior tricuspid valve leaflet, smaller septal, and then the largest anterior tricuspid valve leaflet. See our moderator band that sits in here, and this moderator band points right up to in here where you've got the atrioventricular, the AV node. Okay, and this is when they're doing tricuspid valve surgery or minimally invasive surgery. They've got to be really careful they don't obviously impair this in any way. And if you're having surgery, you make sure that there's no stitches or anything go through this area, because this is obviously where the electrical system of the heart comes through. In terms of papillary muscle, you've got a larger anterior. So it's the largest anterior papillary muscle. I think I've sort of accidentally sort of cut that in two maybe. But that's supplying your anterior, and it's sending off cordae to your posterior tricuspid valve leaflet. And then you've got this larger sort of two-headed, and it can sometimes be separated, this posterior papillary muscle. These are tertiary cordae that you can see coming off here, where there's no papillary muscle, but you can see this tiny little papillary muscle, maybe just at the back, if I can show you that. And that's the septal papillary muscle, which is supplying both that septal leaflet as well as that larger anterior leaflet. Okay? So it's sometimes tricky to know when you're looking at your imaging through here what tricuspid valve leaflets you're trying to pick up. But if it's associated with the free wall, it's going to be your posterior, most likely. It can be some of the anterior. If it's associated with the septum, it's most likely to be your septal one, and then you can get cuttings of your posterior that come in there. So septal associated with the septum, anterior and posterior associated with the free wall. Anterior, front of the heart, posterior at the back of the heart, obviously. I'll ask you to notice, just as I know we're talking about valves, but I can't not talk about the right ventricle, obviously. Look how thin this RV free wall is compared to the thickness of this LV wall. And that's because of the higher pressures that it has to deal with on the left ventricle, as opposed to the right ventricle, which is into that low pressure, high compliance system. The other difference between the right ventricle and the left ventricle is you look at the angle that the blood comes in and out. So here, if you get blood coming down from the atria into the ventricle towards the apex, it goes out. If I push this through to go out of the pulmonary valve, it goes out at a far more sort of obtuse angle. So it comes in at that direction and it goes out in that direction. As opposed to the LV, where blood comes in that direction and goes out through the LVOT in that direction. So it's very axial, if you like. So it just comes in and out along a similar plane. Right ventricle, it comes in and out at a far different plane. Last valve we'll have a look at will be your pulmonary valve. If I feel my way up through there, I'm going to make an incision through the RVOT. Chop that moderator band as well. And here we get to see the semilunar valves of our pulmonary valve, of our semilunar valves of our pulmonary valve. 1, 2, 3. See this smooth-walled RVOT as opposed to the heavily trabeculated portions of the RV. Again, there is a three-dimensional structure to your pulmonary valve. And it's got a ventriculo-pulmonary border at this base where they insert. And there's sinotubular junction of their own in that pulmonary artery where the top part of that insertion point is. And it's that junction right at the top that helps prevent regurgitation. Again, I find it hard to pull it down because of those insertion points at the top. So it's that three-dimensional structure that helps prevent regurgitation. Regurgitation is super common, but severe regurgitation isn't, and it's probably one that's most easily missed. I really hope that was useful. That's a quick overview of valvular anatomy, linked in with hopefully showing you some echo images as you go through it. And that's all about just trying to, again, highlight the importance that you've got a three-dimensional structure, but a two-dimensional imaging tool. And particularly with valves and looking at valve flows, you've got to interrogate that from multiple different angles. Apologies again, I couldn't be there in person, but I hope that was useful. Thank you very, very much for listening.